Yes, sir. Go ahead.
Yes, sir.
Thank you very much, sir. Respected chairpersons and dear friends, I'd like to thank the AOS and Dr. Nirmal for this opportunity. I have no financial interest, nothing in the picture, in the form of picture about hospitals, personal image, we don't mean anything. And most of the data here are from most standard references. Last 2 decades have been excellent for infection control. The fear of getting endophthalmitis and cluster has made us change infection control practices to a great level. So our results are better than the best in the entire world. We have been neglecting this acute conjunctivitis a little bit, but today with the fear of COVID being part of the tier, we are taking care of that. But today we have this coronavirus, which is chasing us and changing the world upside down. All of us have to be very optimistic and think about a corona-free world very soon. But at this point in time, we need to be realistic, and it is definitely possible to create a free zone, if not the world. What I mean is, we can make our hospital and our OT corona-free zone by proper filtering, screening. We have some more way to go regarding this, but it is possible. First thing we need to understand, when is this pandemic going to end? It is not going to be 2 months, 1 month, 3 months. It will be like 2019, 21, 19, 22, something like that only. When there is herd immunity developing as a part of active infection across the world or passively immunization. If active infection has to occur amongst everybody or 50 to 60% of the people, we'll end up losing tens of crores across the world. There is a number called reproduction number. For measles, a single person can contaminate 12 other people, infect 12 other people. For corona, it is at least 1/3 less. So according to this number, we need to have at least 50% of the people to be immunized. A good herd immunity would be when we have 90 to 95% people. That means what? As you can see in the last image, there is nobody to which this virus can spread, only few people. Then we will call it at the end of the pandemic. So we have seen the pre-COVID era. It was a beautiful infection control practice. At this point in time, we need to call it only a COVID era. Only at this point, we are in the stage of lockdown. After lockdown, we have a long way to go. The World Health Organization, Medical Council of India, CDC, and so many organizations, we are having updates 3 times a day, 4 times a day. It is getting evolved. So some of the facts are getting evolved. Even in today evening, the ICMR has asked us to stop all the rapid tests because of some defects. Yesterday, they announced that 80% of the people who are found positive are either non-symptomatic or mildly symptomatic. So there are ifs, buts, possible, and some definitely at this point in time. This is the basis of infection control. We don't want a patient or a worker or an employee or any attender to spread infection from one to another. We call this a universal precaution. All patients, all blood and body fluids, all unsterile needles and sharps should be treated as infectious unless proven. But today I would like to change it as all personnel or people. It may be an employee, it may be a patient, it may be an attendant, it may be all persons and air around any use surface, be it operative, surgical, sterile, unsterile use surfaces, sharp or non-sharp, to be considered as a contaminated one. The operation theatre has got so many people inside, so many processes, so many devices, so biomedical waste management, medication, and so on. So guidelines have been provided by AOS, Government of India, the state governments, and various other organizations. Today we got a beautiful copy of the journal, Indian Journal of Ophthalmology, giving very good guidelines. And what a bold statement to say, prepare or perish. But it drives home the point about how we need to prepare. Now, is there a difference between an OPD patient and a surgical patient? As far as the patients are concerned, we need to understand the patient spends a longer time in the hospital and in the operation theatre. More contacts occur and more procedures have to be undertaken. And because of this, if someone with a positive viral load infects somebody else, the viral load into the infected person is going to be a lot higher. So what is going to happen? He can spread more easily and much more people. And if it becomes symptomatic, it can become more morbid and more severe. When does the screening start? Ideally, not before the OT or as an inpatient. For every hospital, it should be at the point of entry for all patients. Histories like fever, cough, headache are very important, but recently some people are talking only about anosmia and taste loss, because in Italy they used to come and say, you lost the smell of wine. And it is said that anosmia comes even before the other symptoms. So this can also be tested at the entry point. So ideally, we need to test all people. If you look at this graph, this is not the exact days, but we have a period of 2 to 3 days before the infection actually shows up, before they become symptomatic. This is the point they can be still infectious and spread the disease, though many of them could still remain asymptomatic. But we need to understand these days, 7-14, could be longer. Even after 2 weeks, a person can get a symptom. Ideal testing will be rapid antibody. When we get good kits and reliable kits, you could test, say, positive or negative. If it is negative, proceed with surgery. If it is positive, you go ahead with the PCR. If it is positive, that means the patient is still infectious and you wait and ask them to get treated for the COVID. If it is negative, you can proceed with the surgery. The other way is to go for RT-PCR and rapid antibody test. If both are negative, or if only the antibodies are positive and PCR is negative, we can proceed with surgery. This can also be subdivided as symptom-free, non-suspicious into only rapid antibodies, and those with symptoms, known case of COVID or with the history of contact, we can go ahead with RT-PCR and rapid antibody. But at this point in time, we need to know that the sensitivity of all these tests are not reliable, not 100% perfect, and there could be variations, as the ICMR informed today regarding the rapid tests. So surgeries currently, definitely during the lockdown period, it is advisable not to take up elective surgeries. Only emergency surgeries where vision threatening conditions are there. Now what happens when you start elective surgeries? You need not change any of the protocols. It has to remain the same until we get a clear view of there is no risk for corona. But I think the corona is here to come to stay, and we have to learn to live against the corona. When to start is a very big question. Unless we are prepared and sure that a corona will come, we do not want any complications occurring because of a corona to the other people, the form of general health. What to avoid is avoid GA cases and DCR, and the same protocols, whether it is emergency or elective surgeries. Counseling is a very important aspect. The consent form should be taken regarding the corona. Patients and the attenders should be explained about the personal protective equipment, regarding hand hygiene and social distancing whenever it is possible. This is very important at the entry point itself, so that they also learn how to behave themselves in the hospital. Even more than a decade back, WHO said hand washing is the foundation of infection control. At the beginning of NABS implementation 10 years back, we were finding it so hard to get even 5 to 10% compliance for hand washing. But today what it is happening is more than 100%, 150%, because people want to wash twice, not once. And there are wonderful PPE guidelines which have been beautifully explained by Dr. Rajiv. The biggest challenge in operation theatre would be the social distancing. Co-morbidities like sugar, cardiac, renal patients, hypertension, and so on should be tested for not only for the patient, for the employees as well, and get an history from the attender as well. Because you had history of people walking into the hospital with breathlessness, with no other symptoms earlier, get admitted, and within an hour or two, they have lost the patients. So we do not want any of such problems occurring inside the theatre. We need to take extra care for all these comorbidities. The AOS has given wonderful guidelines, and you should need to have daycare. Complete team should be there. Daycare surgeries as far as possible. Avoid general anesthesia, X-ray, and it should be as quick as possible by a senior. And all this have been beautifully explained regarding PPE. Avoid wherever you can get a gas or diafumings. Disinfection after each surgery is very important, and no two patients to be done simultaneously in single cases. Better to shift one after another. A gap of 20 minutes for cleaning is necessary, ideally, because we need to clean the entire theatre, assuming that there has been every surface that is infected. You can also follow alternate teams. One team goes, operate, and comes and gets ready for the next case, and another team starts on the next case. If you have two theatres, you can even take up alternate theater arrangement. Complete sterile set, absolutely complete sterile set should be given for each case, and of course, there should not be overlapping of the instruments or from one case to another. Even the set of medicines should be separate for each patient ideally. All this is being followed. Apart from that, it is also better to ask one question about the symptoms again before shifting the patient to the theater, and minimal surface contact plus following up of the biomedical waste. This is a hood developed by our used by our anesthetists in emergency cases so that intubation and extubation, which is very important, can be done. We have so many reports regarding the life of these viruses in so many surfaces. So we need to understand that every surface has to be clean, avoiding, of course, minimal contact by all the personnel. 1% sodium hypochlorite is the norm to use for all surfaces. Whenever you want to dip something or you want to use the sodium hypochlorite for use the PPE and all those things, you can use 0.5%. Linen management has already been touched upon. Ideally, you wash with 0.5% sodium hypochlorite, or you can use Lysol or phenol. The bag should be labeled if you have a suspected patient. 60 degrees temperature will clear the virus. It will decontaminate the virus. What is the use of validation and OT surveillance in COVID times? Yes, it is important. We should not lose sight of the complete proper sterilization methods, because we are also working against the endophthalmitis. There are physical, chemical and biological indicators. The physical indicators just tell what has been the temperature, exposure time and pressure. They are just printouts. Chemical indicators, there are 6 types. What we are interested in is class 2, which talks about the vacuum. And the class 5 and class 6 are the ones which talk about temperature, steam and pressure. Here you can see the class 5 indicators. So all the 3, if they are up to the mark only, we will get this positive. These are all pack indicators. So ideally, it should be there in every surgical pack so that the surgeon would be able to see. They are not load indicators, so that they will know what they are operating on with the instruments. This Bovitix test is to make sure that the vacuum is proper. Biological indicator uses Bacillus stereothermophilus, and today we have indicators which can be read by rapid readers within 60 minutes, and we can make sure the autoclave process was good. Whenever there is a contamination or an expired drug or any instrument being given, we need to recall them to prevent any further catastrophe. Surveillance of nosocomial infection is an important aspect in this part of the time. COVID-19 has become a notifiable disease. As an eye hospital, whenever we have a suspicious case or known case of COVID, it is our duty to respond to the governmental agencies. Operation theatre surveillance is not done as a routine. It is done randomly. However, we can do it whenever we start a new OT or outbreak, or when there is a hazardous environment of a quality assurance. We have to surveil. The surveillance should be undertaken for air, water, consumables, surfaces, equipment and staff properly. The high risk area in a hospital is operation theatre. The National Program for Control of Blindness says it should be done once in a fortnight. Central Pollution Control Board has given guidelines. This is for any suspected or confirmed case of COVID-19, how to use the biomedical waste. As a hospital, we need to consider that we do not know whether they are suspected or not, because they could be asymptomatic. The rule is you need separate labeled covers, double covers as Dr. Gagan said, clean with sodium hypochlorite. You need to have separate records if you are having a suspected or a COVID-19 patient. These rules, which are amended in 2018, have not changed, are being used continuously. Here you can see the marking also there in the bins. The most important rule of biomedical waste management is segregation at source, which will make it easier, not compiling all the biomedical waste together and then segregating later. Whenever there is a deviation or near miss in the operation theatre procedure, we need to have a correct action taken, preventive action and the root cause analysis to prevent further actions and documented. How to go about this is proper training. We have to reinforce the HIC protocols, talk about COVID-19 disease and PPE wearing and degloving and all those things. Step-wise checklists at every point of time, and they should be taught to do anything when something goes wrong and whom to call. The training should be defined. It should be short, interactive group training sessions, post-training evaluation and supervision while implementation. Code 19 is used for whenever there is a patient who needs need to be intubated for a ventilator. we developed the code yellow. When there is a suspicious patient at the gate or any point of time, we call code yellow, and a specialized team will come and take over that patient, talk to them, make sure that they are suspicious, and talk to them properly, because every employee may not be able to talk properly. So this has been very useful without causing much of panic. What we do not want to happen is, definitely we do not want positive patient, attender or employee causing a cluster and the hospital getting shut down either partly or completely. An Italian doctor's message to the government about this famous saying called physicians heal thyself. They modified that and say healthcare worker protect thyself. It has so much meaning and it is important. We need to remember Dr. Lee, who's an ophthalmologist, who's a whistleblower and talked about this SARS-like virus spreading in Wuhan. He contracted corona from a glaucoma patient and subsequently died in February this year. And 2 doctors who lost life recently in Chennai did not even get the honor during cremation. And to all the corona warriors who have given their lives for our sake, definitely their sacrifice will not go in vain. We will come successful against this deadly virus. In a hospital, you are going to be the person for every individual to control the infection. I would like to acknowledge the valuable expertise given by infectious disease specialist from Apollo Hospital, Dr. V. Ramasubramanian. Remember this, we can create a COVID-free zone and successful. Thank you very much for the opportunity.
Thank you so much.